As we all know, H. pylori is extremely prevalent in our region and Africa as a whole, as well as South and Eastern Asia. We have a prevalence rate here of around 60% in some studies to even above in some studies. And over time, we're realizing that we realize it's very important for us to have a very good scheme to help guide how we search for and treat H. pylori in our region. So we all know H. pylori there's a background underlying risk of H. pylori proceeding and giving somebody a gastric cancer. However, it is very, very low in our region. We thank God for that. However, still, despite all that, it's very, very important that we do have a very, very clear way in which we manage the disease. So first of all, we took people through how we go about the diagnosis of H. pylori, who to test in the first instance. So ideally, we should limit our testing to patients who have features of dyspepsia. Dyspepsia is a very, very broad term for acid-related disorders in the stomach. So that's the first thing that's very, very important. Secondly, it could be important for us to also test family members of patients who have cancer of the stomach. That's another group who will require testing. And as well as patients who have any features of iron deficiency anemia or any of the other blood anemia disorders, microcytic anemia, etc. So those are probably the 3 or 4 groups of patients who ideally we should look for H. pylori in. The general population, probably not an advisory which we have at the moment because, as I said, we have a very low relative risk of stomach cancer in our region. So how do you test for H. pylori? Ideally, there are a number of methods we have either non-invasive and invasive methods. The non-invasive methods are those which you're able to test using a simple blood or stool samples or breath test. So we are trying to phase out the blood test because it's an antibody test. Antibodies, as we all know, can remain at a very high level and detectable levels in your bloodstream for long periods, even if you do not have the active infection. So that's a test which we're really trying to phase out. What we have, which we are advising us to use in our region, is probably the stool test for the antigen, or what they call the urea breath test. So it's a new, not really new, but new in our area. We're now having centers who are installing the machinery, where it's a simple breath test. You just breathe into a machine, and it picks up urea in your breath, and it's able to detect if you do indeed have the infection of H. pylori. So that will probably become a mainstream testing method as we go forward. So when you're done testing, if a patient is positive, then now how do you proceed to treat? There's been an explosion of what they call H. pylori kits in our area for a number of years now. And yes, they do work to an extent, but also the worries are quality of the kits, etc. So we're trying to make it easier for people to be able to follow a very, very clear guideline as to how you treat your patients when they are indeed positive. So we have split the treatment and we have taken off the old nomenclature where we're using first line, second line, third line, etc. And we've now put it in a very, very clear manner whereby now you start with somebody who is the first time you're treating the patient, basically is what they call treatment naive patient. Then you're able to know exactly what pathways to follow. After you're done treating that patient, the very, very important thing for our clinicians to know is you must retest to confirm that you have treated the disease. And usually testing should be at least 1 month after you've completed the therapy. So 1 month without any antibiotics and 1 month without any acid-lowering medication. Then you retest and then you see if you have completed the treatment. For those who you have treated in the past and who are still positive, the guideline also directs you as to how you now proceed with the retreatment, the group who you're using our retreatment. And those who fail on that therapy again, there's now the third phase where now you're talking about now patients who you are requiring treatment failure patients and how you go ahead and you manage those cases. So the guideline document is very, very clear on how to manage patients at the different levels of the therapy. So I think it's a very, very important document, and we're working with the Ministry of Health to try and get them to approve the draft so that now we can move on to dissemination of the guideline around the country. The recommendations basically go in line with getting people, to be able to access the document is very, very important. So we're going to be working very, very closely with the ministry and all other stakeholders in terms of dissemination of the document around the country. We're taking that up as the Gastro Society of Kenya as well as all our affiliates, to try and get the document out there and try to inform our colleagues as to what I've taken you through already in the short clip. The other thing will be probably an appeal to the government in terms of ensuring that there's availability of the molecules which we're using for therapy. There's a new molecule in particular which has come up. They fall under the groups of what they call PCABs. Probably the main molecule in that line is what they call vonoprazan. We've had it now for about 2 years in the region. It has been in Japan and the other sides of Eastern Asia for quite some time though. And it's a very, very excellent molecule, and we're happy that we have it in the region now. So we'll be appealing to the government to try and make these molecules as widely available as possible, because from our guidelines and from the science, there's evidence that these molecules are very, very important in terms of efficient eradication of H. pylori. And efficient eradication of H. pylori without having to repeat therapy, in the long run, is better for everybody, because we're trying to preserve our antibiotics and be good stewards for antibiotic use.